Hello, dear students and esteemed learners. Welcome to my course on Sociology of Health. Now, we are entering into the seventh week of our course, and the theme that I have identified for this week is healthcare structure and major health programs in India. You might be familiar with some of the important health programs. You might have heard the name of National Rural Health Mission or the Ayushman Bharat. These are important concepts in terms of the health programs. Then you are aware of the primary health center, sub center, or a referral center. These are important centers or health organizations. You are aware of the most prestigious institutions at national level like AIMS, All India Institute of Medical Science. Then we are also aware of the kind of health facilities that we have in between the top to the bottom. So, how these different health centers have come into existence and how this is actually operating, what kind of mechanism is there, how do we provide health education, what kind of division of work is operating within the system. There are so many important questions related to the function of the healthcare system. And for understanding that, we need to have a fair understanding of the health structure of India. And so, we'll talk about the various important issues related to the healthcare structure and major health programs in India this week. And this is lecture number 31. And in this lecture, we'll talk about the various health committees and the healthcare in India. Now, you may ask, what is this health committee? So, we'll talk about that. Uh, the governments in the post independence India and even prior to that have been constituting specific committees or the expert committees to make some kind of survey or to make some kind of recommendation on the various health related issues. There can be several issues basically. Anything which is directly related to the health structure or health programming or policies or disease control, anything of any sort of thing. So those committees are constituted for that very purpose, and on the basis of the recommendations made by those committees, the government basically is taking some kind of initiative. So these committees are very important, and we will try to understand the role of the various committees in developing the health structure that we have today, in developing health structure in India, right? So in this lecture I have very briefly talked about the recommendations of some of the important committees like the Bhore committee, the Mudalia committee, the Chadda committee, the Mukherjee committee, the Jungalwala committee, Kartar Singh committee, Srivastava committee, Bajaj committee, etc. Now, what is also important here that the time period basically in which those committees were constituted, because it helps us to understand that at to which period of time what kind of problems were there and how those problems were addressed, right? So a study of the reports of these committee help us to understand in contextualizing the kind of need which might have occurred, right? Or in understanding the significance of those recommendations which were made in those specific contexts. So it helps us to have a comprehensive understanding and have a fair a knowledge about the background in which these institutions and the practices have emerged that we collectively understand as healthcare. So, with this understanding, we move to the first slide, and here the first committee that I have included here is basically the most popular, well-known committee. The technical name of this committee is the Health Survey and Development Committee, and popularly it is known as the Bore Committee, which was constituted in 1943. The Health Survey and Development Committee was appointed by the Government of India, and basically, when I'm saying Government of India, then way back in 1943, it was British India. That is, we are talking about the before independence period. And the committee was appointed to make basically two important things. One, a broad survey of the present position in regard to health conditions and health organization in British India, that is pre-independence India, and second, recommendations for future developments. Right? That means a kind of survey was supposed to be conducted about the status of health of the people living at that point of time, and then what kind of recommendation could be made for making improvement. The Health Survey and Development Committee is also known as Bore Committee because of the name of Joseph William Bore, the chairman of the committee. What is important here is this, that the committee submitted its report in 1946, and it was a very exhaustive report, consisted of 3 volumes. Then a very important point that needs to be mentioned here is this, that the Bore Committee report was concerned only with the then British India, and the 600 princely states did not come within its purview, and this is pointed out by Gupta in one of the articles that was published in the Economic Weekly way back in 1962. The Bore Committee defined health in following words. The term health implies more than an absence of sickness in the individual and indicates a state of harmonious functioning of the body and mind in relation to his physical and social environment. So, this is the basic understanding on health that the Bore Committee was having. Then, it is also important that this committee basically made a survey about the existing health condition, and the figures that it collected is not giving a very positive picture of health in those days. Actually, it's a very painful, because it's a very miserable condition. Let us try to see some of those figures. 50% of the children died before the age of 5. Primary health care was very rudimentary or non existent. Life expectancy at birth was around 26, and infant mortality rate was around 162. And the crude death rate was around 22, and maternal mortality rate around 20. And here you must notice that it is maternal mortality rate, not a ratio, as we discussed earlier, and this is calculated per 1000 live birth. So it was 20 per 1000 live birth. That means the health conditions were very bad. Only 4.5% of the total population had access to safe water, and only 2% of the people had sewerage facility. The number of medical institutions was few, and trained para-professionals like nurses, midwives, sanitary inspectors were barely skeletal in numbers. So that was a very bad picture. Nutrition front was very grave. Food production, its distribution, and availability of food per capita were all unsatisfactory. So all these information about the prevailing health condition we are getting from the report presented by this Bore committee. So that is very instrumental in developing a kind of understanding about what kind of health conditions were prevailing in pre-independence India. Then we will talk about the suggestions made by the committee. The committee has made long list of suggestions, and actually there are three long volumes. So if you want to study the suggestions at length, then you can go through those volumes which are available in the open access mode, the internet, right? Here I have included two, three very important suggestions which are basically related to the topic that we are trying to understand, that how the healthcare structure developed in India, right? The Bore Committee laid emphasis on integration of curative and preventive medicine at all levels. So we are already aware of the fact that there are two different approaches, the curative and the preventive, right? The preventive is very broad based. It talks about some of the medical intervention as well as some of the non-medical interventions. But at this stage, there is an emphasis on integration of the curative and the preventive medicine. Then this committee also suggested the development of one primary health center. So when we are basically, if we are living in the rural areas, then the primary health centers are quite visible there, right? So when this primary health center came into existence and who were talking about these things, we get to know about these things when we go through these reports. So this committee suggested development of one primary health center manned by two doctors, one nurse, four public health nurses, four midwives, four trained eye, two sanitary inspector, two health assistant, one pharmacist, and 15 other class 4 employees for a population of 40,000, and a secondary health center to provide support to PHC and to coordinate and supervise their functioning. That means this committee made a very categorical recommendation about having the primary health centers and sub centers, and which were very comprehensive, well equipped with manpower. It also recommended major changes in medical education, which includes 3 month training in preventive and social medicine to prepare social physicians. Right. So, because of the adverse situations caused by some of the communicable disease, some of the pandemics that we have studied when we are talking about public health, this committee had suggested that there should be equal focus on the curative aspect as well as the preventive aspect. Then we have the Mudalia Committee. The Mudalia Committee was headed by Dr. A.L. Mudalia, who was appointed to assess the performance of health sector since the submission of Bore Committee report. Because in 1962, we India became independent in 1947. The Bore Committee came before that, right? So from 47 to 62, already 15 years basically passed, right? So just to make an assessment of the situation, this committee was constituted, and this committee advised that the primary health centers, then sub-divisional and district hospitals should be strengthened, and they should provide preventive, curative, and promotive services. So in the Bore Committee, we saw about integration of the preventive and curative, and here we also find mention of the promotive. That means this is how the healthcare institutions are basically absorbing new concepts and expanding. So on the one side, there is a talk about integration, then there is talk about having the primary health centers as well as the sub-divisional and district hospitals, and those should be strengthened. And then at the same time, there is talk about the provision of the preventive, curative, and promotive services. Then we had the Chadda Committee, and in 1963, the committee was appointed under the chairmanship of Dr. M.S. Chadda to advise about the necessary arrangements for the maintenance phase of National Malaria Eradication Program. Now, malaria, we have been seeing that was a big killer. It was also responsible for causation of massive death. And we have seen that this malaria is still a problem, because in the MDGs and SDGs we have found mention of malaria. But there was the National Malaria Eradication Program, and this committee was appointed to advise about necessary arrangement for the maintenance phase of that eradication program. So the committee suggested that the vigilance activity in the NMEP should be carried out by the basic health workers, who would function as a multi-purpose worker and would perform, in addition to malaria work, they have to perform the duties of family planning and vital statistic data collection also. That means there is a discussion on the health personnel or the health worker which would be required, and what kind of function they will have, and to what extent those functions will remain integrated. These recommendations were basically talking about those things. So if as a student of sociology you get to know that how those healthcare practices basically came into existence within the medical institutions, within the healthcare centers. So that is why these things are very important, because as a student of sociology, we need to understand that whatever is existing as of now, how that came into existence. Then we have this Mukherjee Committee, 1965. The government of India appointed a Mukherjee Committee headed by the Secretary of Health, Shri Mukherjee, to review the performance in the area of family planning. Now, family planning was a very important priority or goal for the government, because when we look at development from the economic growth perspective, then we try to correlate the growth of the GDP or GNI and the growth of the population. And if there is a growth in the GDP or the income, but if that is not sufficient to meet with the requirements of the population, then it suggests that there should be mechanism for population control. We are aware of many demographic theories which talk about population and, of course, population control. So, in this trajectory of development, population control became a very important phenomenon. There are pros and cons debates related to the ways and means of population control, but we are not interested in talking about these things. The only thing that we are talking about here is this, that this committee was constituted to review the performance in the area of family planning. The committee recommended separate staff for the family planning program. The family planning assistants were to undertake family planning duties only. The committee also recommended to delink the malaria activities from the family planning, so that later would receive undivided attention. That means on the one side there was the malaria control program that was basically a mass killer, and on the other side there were the family planning related goals and means. So when the workers or the health workers or the health personnel staff when they were supposed to focus on both the goals, then that was basically having some kind of compromise situation for both the targets. So this committee basically reviewed this situation and made certain suggestions. And we also get to know that how the various health programs basically were coming into existence. We will talk about the vertical disease control programs, because when we are talking about the malaria eradication program, then this is known as a vertical disease control program, and we had several vertical disease control programs. So maybe in the next or after that we will talk about the vertical disease control program. But in this lecture we are trying to understand that whichever program was basically launched, then how that basically came into the limelight, or how the kind of understanding was developed at the level of the government, and these committees have played a very important role in this. Then comes the next report, which is actually the Jungalwala Committee, and the Central Council of Health appointed a committee known as Committee on Integration of Health Services in 1967 under the chairmanship of Dr. N. Jungalwala. So this committee is primarily on integration of health services. Now again, you can relate this point with some of the things that we have discussed earlier, because there were different streams within the healthcare services. We have been talking about that. Within the biomedicine itself, there were different streams, and then there were different systems of medicine, the traditional systems of medicine, right? So within a specific stream also, there are several specializations and several approaches. So how to integrate so that a kind of convergence to take place and a kind of appropriate divergence can also get adjusted. So with these types of issues, this committee was constituted, and the committee recommended the integration of curative and preventive health services by the state. So this discussion on integration of curative and preventive had started long back. The Bhore committee has also recommended. Then some other committees also talked about it. But this committee primarily gave a blueprint how this could be integrated. Because here you need to understand one more thing, the dynamics within the system also. Because we have discussed that the Marxists have talked about it, and then Foucault has also talked about it, that there is a kind of power structure operating within the system. So within the medical system also, a kind of power structure was operating, that who is senior to whom, which qualification is superior to which qualification, who should get how much salary, what kind of the order of seniority should be maintained. And when we are talking about integration of two branches or two departments which were operating separately, then all these practical questions were actually emerging, right? And that is why we are studying all those theoretical perspectives. So let us have a look on the kind of suggestion that it has made. Following steps were recommended for the integration at all levels of health organization in the country. One, unified cadre. Second, common seniority. Third, recognition of extra qualifications. Next, equal pay for equal work. Then special pay for special work. Then abolition of private practice by government doctors. Now this point number 6 is very important here. We'll talk about this at a later stage also, when we will again talk about the privatization, liberalization, and globalization, and the privatization of healthcare. But you try to remember this thing, that this committee had made a recommendation which stated that abolition of private practice by the government doctors, and it also suggests that basically the private practice was in use at that point of time by the government doctors. And so some model for integration was suggested, and the system of healthcare basically progressed. Then we have the Kartar Singh Committee in 1973, and it was constituted to form a framework for integration of health and medical services at peripheral and supervisory levels. So again, within the system, some kind of arrangement or some kind of system was supposed to be built up, and integration of health and medical services at peripheral as well as supervisory level, right? And then the various suggestions were made, and one of the important suggestion basically talks about the multi-purpose worker, male and female, right? So the term multi-purpose worker talked about the peripheral workers, and it talked about the male as well as female. Then the recommendation also says that the erstwhile auxiliary nurse midwives were to be converted into these multi-purpose worker, female, and the basic health workers, malaria surveillance workers, etc., were to be converted into multi-purpose worker. Then we have the Srivastava committee, and this committee was supposed to make recommendations on reorienting medical education in accordance with the national needs and priorities, and then developing a curriculum for health assistants who were to function as a link between medical officer and the multi-purpose workers. So when we are talking about integration, then some kind of training or some kind of education that is also required, and so another committee is taking care of that. And then the Bajaj committee in 1986, basically that is also dealing with the health issues and the manpower planning and production and management. Basically, the gradually the healthcare system developed and it engaged a huge manpower, and along with that, experts coming from various fields and then working at different levels. So, for the effective running of the healthcare system, there was the need of taking care of the manpower planning and the management within that. So, this committee was constituted and it has made important suggestions. It talked about formulation of national medical and health education policy, then formulation of national health manpower policy, and establishment of an educational commission for health sciences on the lines of the UGC. So you can have a fair understanding that how this medical education was also developing along with the healthcare systems. So these are some of the important health committees. Now, one last thing which is very important that we need to talk about, that India had its first health policy in 1983 only. So many of the issues which basically were discussed in the reports of those committees could have appeared in the national health policy, but since we were not having the health policy for the first 4 or 5 decades basically, so there was a need of having the problem specific committees, and so these are becoming very important. But in the decade of 80s, we had our first health policy, that is the national health policy in 1993, and then we had the second national health policy in 2002 and a very recent one in 2017. So now the focus shifted to the policies themselves. So this much of understanding is I think very helpful for understanding the unfolding of the health structure and healthcare structure in India. In the next lecture, we'll talk about some other important issues related to this larger theme. So till then, take care.